All right, hello everyone. Welcome back for this week's 12 lead. We have a 67-year-old female this time. Initially, the crew was dispatched for 31 Delta, unresponsive patient, and while they're en route, they get a update that the dispatcher has decided to have the family member start CPR. Doesn't appear to any longer be breathing, and she's not responding at all. So the crew gets there. They do confirm she's got no pulse, she's not breathing. They start CPR right away, and at one point they feel like they get a pulse back. And so after we get a pulse back, the next thing you do, you try to get them more stable. You get a 12 lead to see what's going on, and when they get a 12 lead, this is what they find. And hopefully you don't need more than a second or two to recognize this and know what you want to do about it, because this is one of those rhythms you need to instantly recognize and have a plan in your head. And so immediately, this crew, they jumped right back to compressions. This is not a perfusing rhythm. There's no palpable pulse anymore. And so when you don't feel a pulse, the most important thing you can do is start compressions. We really want to get oxygenated blood to the brain. That's the most important thing. So we push hard, we push fast on the chest, making sure to get full recoil every time so that we can keep pumping that blood while the pump is broken, the actual heart. We're going to pump for that heart, get blood to the brain, and do our best to get that heart to restart. And so in order to do that, those first two initial actions are crucial. You want decreased low flow time, so we want to jump on that chest right away. If there's no pulse, we're doing good compressions. And then next, if this is a shockable rhythm, we want to shock it as soon as we can. And so you want to get the pads on the chest. Typically, the easiest place to do that is as you see depicted here, one on the upper right side and then one on the lateral side. If you're using an AED, you just follow the directions that it gives you. Or if you're an ALS provider, then you can use your monitor. But we want to defibrillate as early and as quickly as we possibly can. Now, don't let that interrupt your compressions, because your compressions are what's going to keep that blood going to the brain. But as soon as you can get that defibrillator on there, get that going and be ready to defibrillate your shockable rhythms, VFib and VTAC. After we do that, we've got good compressions going. We're doing our cycle of 2 minutes. We're watching for shockable rhythms, and we shock them when we see them. You want to be very careful about controlling your ventilations. It's really easy in this setting to get a little excited and a little bit nervous. That's totally normal. But we know that one of the best things you can do for your patients is being really controlled about how you're managing the airway. So if you've placed a supraglottic airway, if you've intubated, if you're bagging, all of these things for our airway maneuvers, you really want to keep your rate between 8 to 10 breaths a minute, and your tidal volumes for an average size adult somewhere between 300 and 500 milliliters with each breath. And that's about a normal size adult BVM bag. That's about half of that. So you don't need to be giving full big breaths every time. Actually, about half of that bag, 8 to 10 times a minute, is very effective and good for perfusing the brain, which is our ultimate goal. And speaking of our ultimate goal, we want this patient to get their pulse back and walk out of the hospital, right? And so if there is a reversible cause of this arrest, we want to be able to find that. And we're fortunate here in Albuquerque to have the option of ECMO. So we run our checklist and see, does this person meet criteria for ECMO or not? In our ECMO criteria, we have a witnessed arrest, we have bystander CPR, we have an initial rhythm of ventricular fibrillation, and I didn't give you an end tidal here, but let's say the end tidal was 35. And there's no suspected hypoxic arrest. This wasn't a respiratory arrest. This wasn't an overdose. It's not a morbidly obese patient that's going to make groin access difficult. And no cancer history or other medical comorbidities that would make ECMO not an option. So this patient actually is a very good ECMO candidate. So if ECMO 1 is available, you can bring them to the scene. If not, you can think about early packaging for this patient and getting them to the hospital, ideally within 60 minutes of collapse, because the shorter that time frame is where we're having to do CPR and they're off the pump, the better it is for their neurological outcome. So consider that ECMO checklist when you have a VFib arrest. If this patient is to stay in VFib and you find yourself shocking more than 2 or 3 times, we call that refractory VFib. And some things you can do to help get your patient out of that, or maybe turn this around. If you have your pads placed on the anterior chest, you can consider moving them to an anterior posterior position. A lot of times this is very effective. And all you're doing is trying to capture the part of the heart with the electricity that may be missed. And so if you move to an anterior posterior position, you may be capturing that refractory part of the heart that needs to get back in rhythm. So a good move there after 2 or 3 shocks, think about changing your vector to anterior-posterior placement. Another thing is your medications. We end up giving epinephrine on our cardiac arrest. The one thing we know about epi is that if you give epi early, it's more effective. After that, it's more questionable, but that first dose of epi, as soon as you can get it on board, can be very effective. And especially in light of ECMO, we know that epi and any medications that you give actually are going to get to the heart a lot faster and a lot easier if you use a humoral IO. Here's your landmarks. You can use your thumbs to put over the shoulder, find that humoral head, and your flow rates, I would compare it to a 16 gauge in the AC versus maybe a 22 in the finger. So your humoral IO is going to give you a lot of really good access with really good flow rates to get your medication circulated. And then if you're still in refractory ventricular fibrillation or VTAC, you can consider your antiarrhythmics. We have 2 options here in the metro area, lidocaine or amiodarone pretty soon. So either one of those you can consider giving. And then things that we don't want to do. So we don't want to give Narcan. Narcan does not restart the heart. That ship has already sailed. The heart has stopped. We need to restart the heart. Bicarb and glucose, we know that giving both of these in cardiac arrest actually can increase mortality and lessen the likelihood of a complete neurologically intact survival. So we do not give those 2 medications in cardiac arrest. The things that we know absolutely help are good compressions with minimal interruptions. So do your best to minimize interruptions in CPR, especially when we're putting on that Lucas device. I know a lot of times it's hard. If it takes 2 CPR cycles to get that on there, that's okay to go ahead and do that. Just keep those compressions going as long as you can. And then really controlling our ventilatory rate will be very effective as well. So these are 5 things we don't want to do. We don't want to give any extra meds that aren't going to help. We don't want to stop compressions, and we don't want to overventilate our patients. And so when we're looking at this patient in VFib arrest, we're going to do good compressions, early defibrillation, and continue with really good ACLS care. And that's all for this week. Thank you for your attention, and we'll talk next week.